Hi there, Dr. Avinash here. This is a very beautiful and short and precise video on the pharmacology of diabetes mellitus. Now, to understand the pharmacology of diabetes mellitus, we need to understand the metabolism of carbohydrates and what insulin does. Okay, so the first thing we are going to do is have a look at the metabolism of carbohydrates. When we eat complex carbohydrates, they enter into our GIT. In our GIT, we have enzymes such as polysaccharidases, which will break these complex carbohydrates into oligosaccharides. And then enzymes called as alpha glucosidase or oligosaccharidases convert oligosaccharides into monosaccharides. Monosaccharides like glucose and fructose, right? These monosaccharides are then taken up by the blood via an active transport process. The usual transport protein is a sodium glucose symporter. Once in the blood, the glucose spreads out throughout the body. Of course, maximum glucose will enter into the portal vein and from there goes into the liver, and from there rest of the body. The rest of the body cannot use this glucose for a very simple reason: the cells just can't take glucose. On the cells of the body, there is a special transport protein called as GLUT. GLU for glucose, T for transporter. So GLUT4 is a special transport protein present on the cells of our body that will allow glucose to enter into the cell only if insulin is present. But we have not even spoken about insulin. Somebody has to release that insulin, right? Only then that door, the GLUT4, will open and glucose can enter into the cell. Now, who will release insulin? It's the beta cells of islets of Langerhans. But there must be a door for the glucose to enter here too, right? Yes, there is a special door called as GLUT1, glucose transporter 1. This is insulin independent. It does not require insulin to open, and as a result, glucose can enter into the beta cells of islets of Langerhans, but not the other cells of the body. Now, the fun fact about glucose is once it enters into the cells will utilize it, make glucose 6-phosphate, fructose 6-phosphate, undergo glycolysis, Krebs cycle. Basically, ATP will be produced. And this ATP is detected by a protein called as glucose sensor. This glucose sensor can inhibit a specific protein, a specific channel on the surface of the beta cell called as the potassium ATP channel. Now, let me explain you what normally potassium ATP channel does. Normally, potassium ATP channel allows efflux of potassium, which means potassium leaks out, and when potassium goes out, positivity goes out and the interior of the cell becomes negative. And this is how the cell, the beta cell of islet of Langerhans, maintains negativity inside the cell and positivity outside the cell membrane. The ATP in the potassium ATP channel refers to the fact that this protein, this channel, will be blocked when the ATP is present inside the cell. Now, ATP does not directly block this channel, the glucose sensor does. So what I meant to say was, when glucose enters into the beta cell of islets of Langerhans, it undergoes metabolism, ATP is produced. This ATP is sensed by glucose sensor. The glucose sensor inhibits the potassium ATP channel. When this happens, potassium no longer goes out of the cell. If potassium does not go out of the cell, it remains inside the cell, which means positivity remains inside the cell, right? Positive ions remain inside the cell is equal to partial depolarization, and it is this partial depolarization that opens calcium channels. The calcium channels allow calcium from ECF, extracellular fluid, to come inside the beta cells, and when calciums come in, insulin goes out, and that's how the level of insulin in the blood increases. Now, there was an experiment carried out to find out whether oral carbohydrates would lead to more insulin secretion or injected IV glucose will release more insulin. And it was hypothesized that because IV glucose would reach the beta cells of islets of Langerhans faster as compared to oral complex carbohydrates, IV glucose should release more insulin. In reality, something different happened. Complex carbohydrate ended up releasing more insulin in the blood. When scientists tried to find out what was happening, they realized that when complex carbohydrates are undergoing breakdown in the intestines, the intestinal epithelial cells release some chemical hormones called as incretins. And these incretins, the hormones, they can act on the beta cells of islets of Langerhans and can cause an anticipatory release of insulin. Very soon the scientists realized that what they are calling as incretin is not one chemical, it is a bunch of different chemicals such as glucagon like peptide 1, vasoactive intestinal peptide, glucose dependent insulinotropic polypeptide, and pancreozyme CCK, to name a few. These incretins anticipate the digestion of carbohydrate. They inform the beta cell that in the intestine carbohydrates are getting digested, glucose is going to come into the blood. Why don't you release a little more insulin before that glucose even arrives? And that is what gives that additional insulin spike. Simple. Apart from that, alpha receptors and beta receptors, which are adrenergic receptor, can act via adenylyl cyclase and cause inhibition and release of insulin. So alpha receptors, when stimulated, cause inhibition of insulin release. Beta receptors will cause enhancement of insulin release. The M-acetylcholine receptor via IP3-DAG pathway and calcium also causes insulin secretion. Now in this entire thing, a small problem was noticed. See, if glucose comes into the blood and it stimulates the release of insulin via glucose sensor mechanism, it's under auto control, right? When the blood glucose level will fall, glucose sensor will stop working, insulin secretion will stop, right? That was not the case with incretins. Incretins will continue anticipatory release unless someone stops them. That someone was an enzyme called as dipeptidyl peptidase 4 or DPP4. Its job was to inhibit incretins. This completes our picture of glucose metabolism. Okay, now what exactly does insulin do? Well, insulin increases the uptake of glucose by the cells. It opens the GLUT4 channel, and GLUT4 channel, when open, allows glucose to enter into the cells. Now there are some cells like liver cells, brain cells, RBCs, WBCs and renal medulla which are not dependent on insulin for their glucose uptake. So these regions are, or these cells are kind of the exception. When diabetic patients get ketoacidosis, even that will interfere with glucose uptake by the brain, and that means in patient of diabetic ketoacidosis, coma is a potential complication. Now, not just glucose uptake is enhanced. Insulin sees to it that the cells utilize glucose, and if they don't want glucose to be utilized, store it. That's done by enhancing glucokinase activity. So glucose can either be utilized for ATP synthesis or converted into glycogen. Now since glucose is abundant, see, insulin will come only when glucose is abundant in the blood. Since glucose is already there, you don't require more glucose molecules, right? That's the reason why insulin will also inhibit glycogen phosphorylase enzyme, so that the preformed glycogen is no longer broken down. The cells will use glucose from the blood, not use glucose from glycogen stores. Simple. Not only this, insulin will instruct the cells to decrease PEP, phosphoenol pyruvate carboxykinase enzyme, and inhibit new glucose formation, no gluconeogenesis. Well, glucose is abundant. Why use fats? Inhibit lipolysis and promote triglyceride synthesis so that fat stores in the body increase. And lastly, it also enhances clearing of any lipids, especially VLDL and chylomicrons from inside the blood. So it reduces the cholesterol, the bad cholesterol levels. This insulin does by enhancing vascular endothelial lipoprotein lipase, the enzyme which breaks or clears VLDL and chylomicron. Well, insulin also enhances amino acid uptake by the cell. So overall, insulin is pro-growth. Amino acids entering into the cells is equal to better growth. Insulin causing glucose to enter into the cell is equal to better energy metabolism. So growth becomes better, energy metabolism becomes better, fat is stored, carbohydrates are stored. So basically growth is what is the basic action of insulin. Well, what happens to insulin if we give it orally? Oral insulin is digested. Our body treats oral insulin just like any other protein. Okay. So never to give insulin orally. It has to be given by injections. In our body, the pancreas make insulin and release it in the veins. The veins of the pancreas eventually join the portal vein, and as a result, liver gets a very high dose of insulin, 4 to 8 times higher as compared to the rest of the body. The T half of insulin is only 5 to 9 minutes, which means for precise control of glucose, this is an ideal molecule. If glucose level goes up, out comes insulin, controls the glucose levels within a matter of 10-15 minutes. And if glucose level falls, insulin secretion stops and the actions of insulin will stop within another 10-15 minutes. So that's how insulin controls glucose metabolism. Let's talk about insulins used in clinical practice. We'll start with the history of insulin so that things are pretty clear. Once upon a time, diabetes mellitus was thought to be the end stage disease. Once patient gets it, he or she is dead, because we had no solution to it, especially type 1 diabetes, zero solution. Banting and Best came up with this idea that there is a chemical present in the blood that controls blood sugar level. Before that, people did not even know that insulin deficiency might cause diabetes mellitus. So Banting and Best experimented with dogs, and they found out eventually by trial and error method that the pancreas is releasing a compound called as insulin, which tends to bring the dog's glucose in control. So this is what they did. They purified some insulin from pigs and cows and buffaloes. They called it porcine from pigs and bovine insulin. Now think about 100-150 years back, the techniques of purification were not that great, right? So whatever extract they could get from the pig's pancreas or the pancreas of ox and cows and buffaloes, they purified to the best of their ability, gave it to those patients who were suffering from type 1 diabetes, and surprise, surprise, these kids, these adolescent, they just stood up on their feet, their glucose level normalized. Banting and Best were hailed as the miracle cure guys for diabetes. They were even given Nobel Prize for that. But the problem with porcine and bovine, the older preparation was the purification process was not good, and as a result about 1% impurities remain. Impurities are basically porcine and bovine proteins. We don't write it as 1%, we write it as 10,000 parts per million, 10,000 per 10 lakh molecules, right? And this created serious side effects. People were annoyed with the side effects, but they had no other option. till scientists came up with better methods of purification, and they came up with highly purified insulin, which was a single peak with a predictable action, monocomponent, only contained insulin, nothing else. So a single peak denotes that when I give insulin, I know when it is going to work, what is the peak it will reach, and monocomponent because only one insulin. Here the purification was so good that the level of impurities became less than 10 parts per million. That is negligible impurities. Well, the problem with highly purified insulins were the lifespan of this insulin was very small in our body. Every time the patient takes food, he has to take insulin, which was kind of ridiculous because if the patient eats 6 meals in a day, lunch, dinner, a breakfast, and 2 or 3 in between snacks, that many insulin injections the patient will have to take. People were fed up of this. So scientists came up with an idea, why not buffer this insulin at neutral pH? So you have a buffered neutral pH solution in which they added unmodified insulin plus zinc. This combination gives you a peak action after 2 to 3 hours, and the action lasts for around 6 to 8 hours, which means now from 6-7 times a day, the number of insulin injections will come down to 3 or 4 per day, depending on how much longer this action is. Simple. So regular soluble insulin for some time worked amazingly. But then people were still bothered giving 3 or 4 injections in a day. Could we delay the action? Can we get a better, longer action? And that's where retard preparation came. Before I go to retard preparation, let me inform you of 2 important MCQs. Regular soluble insulin is not good for constant basal action. It's not a long acting one. And second, even though it is given in subcutaneous, you can give it IV if you wish to have a faster action. Even now you can use regular soluble insulin. One more MCQ I want to add to this is regular soluble insulin cannot be used with insulin glargine and insulin detamir, which is insulin analog. Just remember this, when we come to analogs, you will know what insulin glargine and detamir is. So basic problem of regular soluble was 3 or 4 injections in a day. Why not retard the action, slow down the action so insulin can work for a longer period of time? And we have 2 preparations here, lente and isophane. Lente insulin is of 2 types, ultra lente and semi lente. Let me rephrase that. Lente insulin has 2 types of insulin, ultra lente and semi lente. Ultra lente is the ultra long acting one. This is because ultra lente insulin is made up of larger particles and difficult to dissolve. They're insoluble and they're crystalloids, so they take longer time to act in your body. As compared to semi-lente, which is short acting, it has smaller particle and is more powdery, it is amorphous, so it dissolves better in the body. And you take 70% ultra lente, 30% semi lente, that combination is called as lente, and this works for a very long period of time, bringing down the number of injections to only 2 in a day. Well, we can also have isophane insulin, also known as neutral protamine Hague-Don. This insulin is a combination of protamine plus insulin mixed in such a combination that it's literally 50-50. Neither insulin is free nor protamine is free. Simple. And this is intermediate action between ultra lente and semi lente. So what has been done is a new regime called as the split mixed regime has been formulated. 70% of NPH and 30% of regular, or 50-50, gives you an instant as well as intermediate action. This works fine for some people, but then still till retard preparation we are just trying to play around with porcine and bovine. So highly purified was porcine bovine, just more pure. Regular soluble was porcine bovine just with zinc. Retard preparations were ultra lente, semi lente, isophane. These were porcine bovine with necessary modifications to cause longer action. People were worried about animal sources. Some for religious purposes, some for why not. Some people just oppose because they love to oppose. Luckily, by that time, we had the evolution of genetic technology. And these recombinant genetic technologies helped us create insulin from human gene with the help of bacteria and fungi. So we got 3 new insulins. First is PRB, pro-insulin recombinant bacterial, where an E. coli uses the gene, human gene, to give us proinsulin. A PYR, precursor yeast recombinant, where a fungus, a yeast, gives us insulin, and we made an enzyme thanks to genetic recombination technology, an enzyme that can take porcine insulin and modify it chemically, enzymatically, and make human insulin out of it. So this is enzymatic modification of porcine insulin, and this works brilliantly. Now there was some concern whether human insulin have more potential than porcine and bovine. Will it cause more hypoglycemia? Those fears were rational fears. Luckily, when people used human insulin, nothing went wrong. But we came back to the older preparation problem, which was give it at the time of food, again 6-7 doses in a day, which was unrealistic because people were like, oh, we already had retard preparations once or twice a day. Why would anybody make PRB, PYR and EMP which has to be taken with every single meal? So scientists came up with a better idea. Why not retard the action of human insulin? And that is what they did. They created insulin analogues. These included my favorite 5. There are many more. Insulin lispro, insulin aspart, insulin glulicine, insulin glargine, and insulin detemir. Insulin lispro, remember, insulin has 2 chains, A chain and B chain. On the B chain, position number 28 and 29 is proline and lysine. If you flip the position and make it lysine and proline, you call it lispro. Simple. It can be injected just before meals or during meals. Insulin aspart is when you replace B28 proline, that's 28 amino acid, that is proline, on B chain with aspartate. This is much more closer to the natural human insulin. And for CSII, continuous subcutaneous insulin injection, these are insulin pumps. We prefer glulicine. And for this, what we have done is we have modified it a little bit. At position 23 on B chain is lysine. Remove that lysine, asparagine is there. Remove that asparagine, replace it with lysine. And on B29 position, there was lysine. You remove that and replace it with glutamate. This insulin works beautifully with the insulin pumps. Insulin glargine has 2 additional arginine at the C terminal of B chain, and the asparagine at A21 was replaced with glycine, and you got glargine. Beautiful insulin again. And lastly, detemir is a new one which has a myristol radical attached to the lysine at B29. Simple. And that is how insulin analogues came into being. Fantastic newer preparations. Chances of them coming in your exam a little lesser, but can come. This flowchart will help you understand insulin. But the classification of insulin given in our textbooks, most standard textbooks, is based on their action: short acting, intermediate acting, and long acting. You will have to remember that classification, but keep this concept in mind. Okay? Now that we are clear with the different preparations of insulin, it's time to move on to their side effects. The most important side effect, of course, is hypoglycemia. This is frequent. This is potentially the most serious reaction. And this usually happens in patients who we call have labile diabetes. These people have a variable insulin requirement, so their insulin requirement fluctuates in an unpredictable manner. This can also happen in any diabetic who takes larger doses of insulin, or has taken the regular dose of insulin but has skipped a meal, or has performed vigorous exercise. So these things can lead to hypoglycemia. The symptoms of hypoglycemia can be defined by those because of the counter-regulatory sympathetic stimulation, which includes sweating, anxiety, palpitation, tremors. And second kind of symptoms you will get is because of brain not getting nutrients. We call it neuroglycopenic symptoms: dizziness, headaches, behavioral changes, visual disturbance. Patient might start feeling hungry, fatigued, weak. The patient might have muscular incoordination, and sometimes there is fall in blood pressure. I hope you also know the fact that patients eventually get diabetic neuropathy, and when that happens, these autonomic responses, the sweating, anxiety, palpitation part, does not happen, and the patient loses the awareness that he has hypoglycemia. It's known as hypoglycemic awareness. Okay. The worst would be if the blood sugar level falls to less than 40 mg per deciliter, where mental confusion, abnormal behaviors can happen, seizures and coma can occur. And if not taken care of, if not treated, this will lead to permanent neurological damages because of hypoglycemia. Okay, treatment is very simple: give glucose. If the patient is completely conscious, give 15 to 20 grams of glucose orally. If does not happen, then repeat it again. In severe cases, you might have to give 30 to 50 ml of glucose injected IV. It's 50% glucose injected IV over 10 minutes. Well, people have tried giving glucagon injections IV 0.5 to 1 mg, or adrenaline 0.2 mg subcutaneous. But that's not really the main treatment. Main treatment would be glucose. Simple, simple. The other reactions that are known to happen are local reaction, allergies, and edema. Local reactions in the form of swelling, erythema, and stinging can happen at the injected site, especially before the patient gets used to those pricks. They complain of these local reaction a lot. We also have heard about this word called as lipodystrophy. The older preparations, the pork and the beef insulin, remember we spoke about how it had impurities. So against those impurities, antibodies were made, and every time the patient used to take an injection, the subcutaneous fat around the site of injection would undergo lipodystrophy. The newer preparations don't have impurities, and as a result they are pretty safe. Local reactions don't happen with newer ones. Again, allergies was more to the porcine and bovine proteins. So the human insulin or highly purified insulin hardly have any allergic reaction. Rarely people do use older preparation even now, and then urticaria or angioedema and even anaphylaxis can happen. So be careful. And some people, because of sodium retention, that's an action of insulin, can develop a short-lived dependent edema. More on the foot when the patient is standing, or more on the sacral region when the patient is lying down. And this is what happens. These are the side effects. Now that we know how insulin is supposed to be made, let me bring to your attention the fact that insulin is useful only in type 1 diabetes mellitus and in some cases of type 2 diabetes mellitus, where the insulin level in the blood is low. Okay? Type 2 diabetes mellitus has to be treated with diet, exercise, stress reduction, and oral hypoglycemic agents, which we need to understand in details. For this, let me recap what we have studied at the start of this session. Complex carbohydrates are eaten, they are broken down by polysaccharidases and oligosaccharidases and alpha glucosidases into oligosaccharides and monosaccharides respectively. When this process is happening in the intestine release certain hormones called as incretins. These are local hormones. Incretins include GLP-1, VIP, glucose-dependent insulinotropic polypeptide, pancreosine, CCK. But for us, GLP, glucagon-like peptide 1, is the most important incretin. These incretin go and warn the beta cells of islets of Langerhans about the glucose that is about to come in, and the beta cells then release insulin. This is known as anticipatory release of insulin. By this time, the monosaccharides have got digested, carbohydrates have got digested, the monosaccharides are absorbed, the glucose spreads throughout the body. In every other cell, we require GLUT4 transporter to allow glucose entry inside the cell, not the beta cell. Beta cell has GLUT1. Glucose enters the beta cell, gets converted into energy or ATP. This ATP is sensed by glucose sensor, and glucose sensor blocks potassium ATP channel, right? When the potassium ATP channel is blocked, the efflux of potassium stops. Efflux is getting out of potassium. If potassium went out, the interior would have become negative. But now, because of the blockade of potassium ATP channel, potassium stays inside. This leads to partial depolarization. That partial depolarization opens the voltage gated calcium channel. Calcium comes in the cell, and when calcium comes in, insulin vesicles are released, the insulin levels in the blood start to rise. The actions of incretins have to be controlled, otherwise there will be too much of anticipatory release, and hence we have an enzyme called as dipeptidyl peptidase 4, which will break those incretins and stop their action. Keeping this in mind, let us target the blood glucose level. We have to lower the blood glucose level. How can we do that? One, we can release more insulin by blocking the potassium ATP channel. Don't wait for the glucose sensor to do it, you do it. Simple. There will be drugs which will act at this level. The second category of drugs would be which work like incretins, GLP-1 like. So there will be incretin like substance or GLP-1 like substances. We can even give a dipeptidyl peptidase 4 inhibitor, so that when the patient eats the food, whatever incretins are made in his intestine, they will work for the longer period of time on beta cells of islets of Langerhans. Simple enough. And lastly, we can even inhibit alpha glucosidase, an enzyme that breaks oligosaccharides into glucose. If glucose is not formed in intestine, it cannot be absorbed, and if it cannot be absorbed, there cannot be rise in blood sugar level. Keeping this basic plan in mind, and of course we will be talking about many more mechanisms of actions, let's start with oral hypoglycemic agents, agents that enhance insulin release, which include sulfonylureas, meglitinides, GLP-1 receptor agonists, DPP-4 inhibitors. We have drugs to overcome insulin resistance, including biguanides and thiazolidine diones, also known as PPAR, gamma activator, and some miscellaneous drugs like alpha glucosidase inhibitor, amylin analogs, dopamine D2 agonist, and sodium glucose cotransporter 2 inhibitor. The sulfonylureas can be divided into two main categories, first generation and second generation. The first generation is tolbutamide, no longer used. The second generation is containing drugs glibenclamide, glipizide, gliclazide, and glimepiride. Okay. Meglitinides or phenylalanine analogs include rapaglinide and nateglinide. GLP-1 receptor agonists include exenatide and liraglutide. DPP-4 inhibitors are gliptins, sitagliptin, vildagliptin, saxagliptin, alogliptin, and linagliptin. And drugs which overcome insulin resistance, biguanides include metformin, and thiazolidine diones includes pioglitazone. Miscellaneous drugs, alpha glucosidase inhibitors include acarbose, miglitol, and voglibose. Amylin analog is pramlintide. Dopamine D2 agonist is bromocriptine, whereas sodium glucose cotransporter 2 inhibitor is dapagliflozin. You need to know the classification properly. Moving on to the first and probably the second most, let's say, important drug, oral hypoglycemic sulfonylurea. This is used in type 2 diabetes mellitus, not in type 1 diabetes mellitus. And the first generations are completely outdated. We only use the second generation now. The mechanism of action is very simple. It acts on the sulfonylurea receptor. The sulfonylurea receptor is actually located on potassium ATP channel and blocks the potassium ATP channel. You know what will happen next. There will be partial depolarization, influx of calcium and efflux of insulin. Simple. So this is what our plan is. Block the potassium ATP channel, cause partial depolarization, calcium channel should be open and insulin release should happen. So which phase is augmented according to you? Is it the anticipatory release or the one caused by glucose? The one caused by glucose is enhanced. The anticipatory release was by the incretins, right? So that's not affected. The second phase is augmented or increased. Now for this to happen, for sulfonylureas to work, you will require beta cells, right? In type 1 diabetes mellitus, because of some autoimmune phenomena or some immune dysregulation, the beta cells are dead. That's why they don't have insulin. That's why type 1 diabetes needs injections of insulin. In type 2 diabetes mellitus, the beta cells are working, but there is insulin resistance. The normal levels of insulin cannot do their job properly, and hence you want more insulin, but you also want beta cells to be there. Sulfonylureas will use those beta cells, at least 30% of the 100% present in pancreas in a normal human being. At least 30% should be there. Then those 30% will be forced to release more insulin by sulfonylurea. Isn't it simple? Now, apart from this, sulfonylurea also has an extra pancreatic action. And this extra pancreatic action takes time. Okay, it's going to take some time to develop. The extra pancreatic action is basically the down regulation of insulin receptor, the decrease in number of insulin receptor is reversed. So now the insulin receptor numbers increase. Okay. This is important. This sensitizes the target tissue. You know, if it has better number of receptor, then the glucose will work better, the insulin will work better, the glucose metabolism will become better, right? So by reversing the down regulation of insulin receptor, like up regulating the insulin receptor, the insulin now works much better, especially in all the target tissues, including the liver. Okay. Now the good thing is, when you think in long term, if sulfonylureas can bring the circulating insulin concentration slowly and gradually down, because the carbohydrate tolerance level is increasing, then the beta cells get rest, the receptors are adequate in number, and the actions of these receptors improve. So kind of enhancing the decreasing the insulin resistance is what sulfonylureas can do in the long run. Unfortunately, they are sulfonylureas, they are sulfur containing drugs. There will be some side effects. These side effects include hypoglycemia. For obvious reasons, these drugs are forcing extra insulin in the circulation. So this is a common problem, and occasionally it can be serious or it can even be fatal. This is more common in elderly people or patients who have other diseases like kidney problem, liver problem, or when two potentiating drugs are added. Now out of all of this, tolbutamide carried the lowest risk, but it was because the potency was low and the duration of action was also very low. How do you treat hypoglycemia? Just like you treat hypoglycemia of insulin, by giving glucose. Okay, now it's necessary to continue this glucose maybe for a few days, because hypoglycemia tends to recur in these people. The second important side effect is a non-specific side effects, like gaining weight, like almost 1 to 3 kg weight gain happens at the start of this therapy, maybe because of the insulinemic action. Nausea is there, vomiting is there, gas, flatulence, diarrhea or constipation can happen. People complains of headaches and paresthesia. So make your patient aware of these problems and tell them not to get worried. The third important side effect, of course, is hypersensitivity reaction. It can be as simple as a rash to as horrible as photosensitivity, purpura, leukopenia, or granulocytosis. People who take alcohol have to be warned, okay, because these medicines cause a disulfiram like reaction when mixed with alcohol, so be very careful. Plus tolbutamide reduces iodine uptake by thyroid, but somehow hypothyroidism does not happen. Okay, whether you should give it in pregnancy or not is debated. It's better we prevent, stop this medicine, especially during pregnancy. Moving on to the next category of drugs, that is diphenylalanine analogs or megalidinides. They are drugs specifically designed to normalize mealtime glucose excursion. See, when a person has food, his glucose level will rise in the next half an hour, right? Half an hour, 1 hour, whatever time it takes to digest that food. That can be normalized by taking repaglinide and nataglinide. Repaglinide is the faster acting, okay, quickly absorbed, very fast, and short lasting. Both these repaglinide and nataglinide would cause insulin release. So fast acting, short lasting insulin release will be done. Ideally given before a meal to control postprandial, PP is postprandial or post lunch hyperglycemia. These drugs are good enough. Okay, if the meal is not taken, you skip the dose, right? And because it's a short acting drug, the chances of hypoglycemia also is less. Unfortunately, some side effects do happen, including headaches and joint pains and weight gains. And try avoiding repaglinide in liver disease. Nataglinide also has a faster onset, shorter lasting action. It causes hypoglycemia, brings the blood sugar down. Given 10 minutes before meal, it works beautiful. Its side effects are slightly different. Like here you get nausea and you get flu-like symptoms and joint pains. Other noteworthy MCQs that can come from nataglinide is the fact that it can stimulate the first phase of insulin secretion. So it has a faster onset, that's why it's faster onset, better than repaglinide. And that's the reason why it is good in type 2 diabetes. It does not cause late hypoglycemia. It does not work for a too long period of time. As far as fasting blood glucose levels go, it does not work on those. And you can use this with other anti-diabetic, especially if the patient has a problem controlling post post-meal hyperglycemia. Then this is a very good drug, nataglinide. Which brings us to GLP-1 agonist or glucagon-like peptide 1 agonist. Well, we know the fact that GLP-1 is an incretin, and the GIT makes it in response to the ingested carbohydrate, and it causes anticipatory release of insulin, and in the process also inhibits glucagon. So glucagon levels fall and insulin level rises because of GLP-1. Okay, now GLP-1 will cause release of insulin only at high glucose concentration. Okay, the thing that we have noticed about GLP-1 is it makes the beta cell healthy. It's kind of health promoting actions. They decrease islet cells apoptosis. Many doctors believe that in some cases of beta cell dysfunction of type 2 diabetes mellitus. It is the failure of incretin which is responsible for the beta cells dying. And especially as the disease progresses, maybe the lower and lower levels of incretin in these human beings, the type 2 diabetics, is causing more and more destruction of their beta cell. So if you want to preserve beta cell functions, logically GLP-1 agonist would be the best one. Okay. Now GLP-1 cannot be given directly because DPP-4 is destroyed. And DPP-4 is in many places on the lumen of the capillaries, endothelial cells. So basically, even though we have GLP-1, we can't use it, and hence we are starting with this new concept of using agonist exenatide. It is DPP-4 resistant. It is not going to be destroyed by the dipeptidyl peptidase 4 enzyme, which means it will activate the same GLP-1 receptor, produces the same response as the natural GLP, but does not get destroyed. This is inactive orally because this is a peptide, and peptides cannot be given orally because it will get destroyed. You have to give it subcutaneous injection. The T-half is around 3 hours. Okay, now before I go to liraglutide, let me help you out a little bit with exenatide. You have to give this subcutaneous before breakfast and before dinner. This is an add-on drug to maybe sulfonylureas or maybe metformin or maybe any combination. Okay, the postprandial as well as the fasting blood sugar level decrease in patients who are taking exenatide. Their HbA1c levels become more towards normal, and their body weight also becomes normal. Simple. Apart from minimum side effects like nausea and vomiting, nothing much goes wrong in these patients. Okay, some patients have developed antibodies to exenatide, but not much of a problem. Very important MCQ, exenatide is known risk factor for acute pancreatitis. Okay, which brings me to liraglutide. This is a long-acting GLP-1 agonist. This has a tighter plasma protein binding, and that's why it has a longer T-half of 12 hours. The duration of action is more than 24 hours. Now with insulin and all insulin-like drugs, weight gain can be a problem, and hence liraglutide is good because it is known to cause some weight loss. Okay. Now, even in so basically, if it causes weight loss, wouldn't it be a great idea to give this in diabetic who are obese? The good news about liraglutide and exenatide is the fact that they don't cause hypoglycemia. Even when they are given in monotherapy or in combination, they hardly cause it. Acute pancreatitis can happen, but nothing much to pay attention to. But both liraglutide and exenatide are not given alone. Usually they are given in combination with sulfonylureas, metformin or something like that. And they are always effective in type 2 diabetes, not in type 1. We also have albiglutide and dulaglutide, which are very long acting GLP-1 antagonists. They actually need to be taken once weekly. But right now they are not available in India for use, and they are not that important too. Why not allow body to make incretins? You just stop their breakdown. Let us make DPP-4, that's dipeptidyl peptidase 4 inhibitors. In that way, we will be able to stop the breakdown of in endogenous GLP-1. Okay, and the good news is these are orally active, so you don't have to give injections. Though they are recent drugs, we have noticed that people who have taken DPP-4, they show a better sugar control when combined with other drugs. By themselves, DPP-4 inhibitors don't have that good control. It's a moderate control compared to sulfonylureas. The first DPP-4 inhibitor was sitagliptin. This drug enhances the action of naturally released GLP-1. Okay, and as a result, it will only act when there is natural GLP-1. Alright, it will not allow its breakdown, sitagliptin. If the person does not eat the food on one particular day, will incretins be released? No. So will DPP-4 inhibitors cause hypoglycemia? Absolutely no, right? Now by inhibiting DPP-4, you increase the time GLP-1 and other incretins work, and as a result the postprandial insulin release increases, glucagon secretion decreases, meal time increase in sugars as well as fasting blood sugar levels becomes low. Good. Another great thing is it has no effect on body weight, has a very good HbA1c lowering action, and is better hypoglycemic as compared to all the other DPP-4 inhibitors that we are going to discuss in some time. It does not have any effect on gastric emptying, nothing on appetite, no hypoglycemia itself is a great thing. The HbA1c lowering achieved by sitagliptin is as good as that with metformin. So if you add it to the combination, it will be like amazing. See, when metformin cannot be used, sitagliptin can be given alone. Otherwise, this is an adjunct drug. So give with metformin or sulfonylureas or pioglitazone. Okay. This is what you need to know. All these drugs are going to be absorbed orally, and only in kidney impairment you might have to change the dose of sitagliptin. Nothing much has to be done here. Like, you know, whatever I just spoke about and the sitagliptin part that is written here, more than sufficient. Vildagliptin is the second drug of this category. This binds to the DPP-4 enzyme covalently. It dissociates slowly and hence it is longer duration of action, but it is unfortunately less selective for DPP-4. Some people have reported hepatotoxicity, okay, because the levels of enzymes, liver enzymes go up. Vildagliptin twice a day dosing is sufficient, but many cases only one daily dose is fine. Okay, especially if you combine it with other hypoglycemic, then one dose should be fine. Simple enough. Moving on to the next DPP-4 inhibitor, saxagliptin. This also binds covalently and as a result works for 24 hours. The plasma TF is only 2 to 4 hours, but because it is bound covalently to the enzyme DPP-4, the action is longer. Saxagliptin has an active metabolite which has a higher T half, and that's how it probably must also be working. Now this much you know, that's great. There's also teneligliptin. This is the latest one developed in Japan. Again, more than 24 hours of control. It is anti-hyperglycemic, it's anti-DPP-4. A single morning dose is good. So one dose, all 3 meals of the day are covered. Breakfast, lunch, dinner. So again, just like others, give it with other drugs. You can give it alone. That's that. There's nothing great. There's nothing great about teneligliptin. It's just the newer variety of it. There's also algogliptin and linagliptin, which we do not study as a part of our pharmacology. Now, moving on to the next topic, which is biguanides or metformin. If sulfonylurea was the second most important answer, metformin is the most important answer from this particular chapter. Got it? Metformins are amazing. They rarely cause hypoglycemia. They improve lipid profile of the diabetic patients. They have a mechanism of action which is not via insulin. They activate something called as AMP dependent protein kinase. Now, AMP dependent protein kinases are enzymes that can activate a lot of other enzymes, okay, and it's kind of a mediator. The AMP dependent protein kinase, it's a mediator, and it activates other enzymes which do the following things. First and foremost, they suppress hepatic gluconeogenesis. Remember, we already know this. The glucose in the blood is maintained, the glucose level is maintained by hepatic gluconeogenesis and glucose output from the liver. If you suppress hepatic gluconeogenesis, the glucose coming from the liver decreases and the blood sugar level will fall in case of diabetic. The second thing it does is it acts on the peripheral cells and it enhances insulin mediated glucose uptake. As a result, the skeletal muscles, the fat cells pick up more glucose. Now, if more glucose is picked up, the glucose level in the blood decreases. Isn't that so? Now, what will these cells do of this extra glucose? Store it in the form of glycogen, or use it in production of adipose tissue, or even fatty acid oxidation can be done, right? So this means the resistance, insulin resistance in type 2 diabetes is overcome by taking this particular medication. The third thing it does is it interferes with the electron transport chain. Now, electron transport chain present in the mitochondria, when it works properly, it gives you ATP and little heat. Cells require X number of ATPs. They will break X number of glucose molecules to get X number of ATPs. What if we make a medicine that shifts the glycolysis from aerobic to anaerobic by interfering with this respiratory chain? Aerobic glycolysis gives around 36 to 38 ATP molecules. Anaerobic gives only 2. So now for X number of ATPs, you're going to require 18 times more glucose molecules, because 2 and 36 is like 18 times different, right? I hope you're getting it. So by shifting the metabolism temporarily to an anaerobic kind of a system, glucose utilization is improved. So if the glucose utilization improves, then what will happen? The glucose level will fall. Okay, simple enough. Now, it also retards the intestinal absorption of glucose, hexoses and amino acid. Now this is additional effect. Now if glucose is not absorbed, the levels will be low. Unfortunately, amino acid and even vitamin B12 levels might just decrease, because biguanides metformin can decrease its absorption also. The adverse reactions of metformin are important. Okay, not serious but important. This starts with abdominal pain, anorexia, bloating, a typical metallic taste, sometimes diarrhea and tiredness. As a rule, we never use metformin in hypotension, cases of heart failure, severe respiratory, hepatic or renal disease. Simple, easy to understand, right? Now, the advantages of metformin over all the other medicines that we have studied is the fact that metformin does not cause hypoglycemia. Compared to other drugs, metformin is a weight loss promoter, and as a result the weight will be controlled, especially good for obese diabetics. It prevents micro and microvascular complications of diabetes mellitus, and it has got nothing to do with beta cells. Remember the sulfonylureas, they were stimulating the beta cells. DPP4 inhibitors stimulating the beta cells indirectly. Incretins, GLP-1 like agonist, stimulating the beta cell. Well, beta cell has limited lifespan, it has a limited workload. If you stimulate it too much, it will get burnt out, it will die earlier. Biguanides do not cause beta cell burnout because they don't work on beta cells. And compared to other medications that we have been studying, this has a better HbA1c reduction. The best is the fact that it does not interfere with any other medications. So you can give it in any, with any other oral or injectable anti-diabetic. Okay. The beautiful aspect of this drug is, if you give it to a patient who has glucose intolerance, impaired glucose tolerance, not glucose intolerance, impaired glucose tolerance, who is like borderline diabetes, is obese or middle aged, and they start on metformin, they don't get diabetes. Simple. So that's the only drawback of, I mean, not the drawback, that's the only beautiful thing about metformin, because of which we love metformin so much. Metformin is an LAQ. Moving on to the next category of drugs called as alpha glucosidase inhibitor, a carbose, rarely asked question. It acts on the complex oligosaccharide. This is a complex oligosaccharide. It blocks the alpha glucosidase enzyme, and as a result, oligosaccharides are not converted easily into monosaccharides. So they are slowing down digestion. Now, when they slow down digestion, the digestive process happens for a longer period of time. More GLP-1 will be released. They lower HbA1c, but they don't have that much effect on weight and lipid profile. They just don't allow glucose to come into the body. They are anti-hyperglycemic. Okay, digestion is not going to happen, so absorption cannot happen. Given in the dose of 50 to 100 mg 3 times a day at the beginning of the meal, so major meals, breakfast, lunch and dinner, you take this, the patient should be fine. The problem is the undigested carbohydrate now reach the large intestine where bacteria is fermented. And when the bacteria is fermented, they release gases, and hence a carbose is known to cause flatulence, abdominal discomfort and loose stools. There is no liver damage per se, but we have noticed a rise in the hepatic transaminase level. Miglytol is a stronger inhibitor of sucrase enzyme, whereas voglibose is just like a carbose, and that is what you need to know. Which brings me to the last medicine you need to do, pioglitazone. This is a PPAR gamma agonist. Now PPAR stands for peroxisome proliferator. PPAR is peroxisome proliferator activated receptor gamma. Basically, this is a gene present inside the DNA of our cells. When agonists act on PPAR, the DNA gets converted to RNA and RNA gets converted into proteins. The PPAR gamma gene is more important in fat cells, muscle cells and some other cells of the body. So when PPAR gamma agonists work, they enhance transcription of insulin responsive gene, which means all the actions of the insulin will now be enhanced even with little insulin. They enhance GLUT4 expression, they help GLUT4 reach the cell membrane so that glucose can come in, they lower triglyceride level, they improve HDL levels also. HDL is good cholesterol. The only side effect is they can cause a little edema-like condition. Plasma volume expansion happens because of them, and weight gain is there. Some people have complained of muscle pains and anemia and increase in risk of fracture. Don't give thiazolidinediones, pioglitazone in hepatic disease and congestive heart failure. In order of importance, please do metformin first, followed by sulfonylureas, followed by GLP-1 agonist, followed by DPP-4 inhibitors, followed by thioglitazone. Lastly, do a carbose. I hope you have understood this. If there is any doubt, please drop in a message and I will be more than happy to help you. Till the next time we meet, this is Dr. Avinash signing off for now. Take care, keep studying and keep rocking. Bye bye.